Hi, everyone, and welcome to today's Research America Alliance discussion. I'm Ellie Dehoney, the Vice President of Policy and Advocacy with Research America. First, I'd like to say thank you so much for joining us today and for your organization's partnership with Research America. If your organization is not a member, join us. It's going to be Dr. Valdez, close your ears here. It's going to be a tough road this year and next to secure federal funding for AHRQ, NIH, CDC, FDA, NSF, and other research agencies. We need to advance progress. Then there's the fight for pandemic response and preparedness funding, for timely passage of PDUFA. The list goes on. The hundreds of organizations who are already members of Research America are the force that enables us to make a difference. And we'd love for you to join us. And if you're not sure what membership entails, call me or email my colleague, Anna Platt. Her email should be in the chat. We will promise not to talk your ear off, although I'm fully capable of it, as you all know. Our special guest today, as I mentioned, is Dr. Robert Valdez. He is the new-ish director of the Agency for Healthcare Research and Quality. And Dr. Valdez, it is such an honor to host you. You're leading an agency that really holds the key to saving millions of lives, trillions of dollars. It's so important to understand your vision and objectives for, let's face it, an underappreciated and outsized important U.S. asset. As always, please type questions into the Q&A box or chat. We'll pose as many as we can during that portion of today's session. And Dr. Valdez, with that, over to you.
Well, thank you, Ellie, and thanks for inviting me to chat with you, because you're absolutely right. AHRQ is a gem of the department that nobody knows about. When people talk science, they think NIH, but NIH is only one important agency that does science in the department and that moves our health and healthcare systems forward. NIH, and they've supported a lot of my work over my career, really focuses on biomedical research. And AHRQ is, as you suggested, really focused on how we transform those discoveries, those scientific discoveries, into real evidence-based clinical therapies. Next slide, please. You know, we're the only agency, and most people don't know, that Congress has given this particular set of authorities for. It's the only agency in the department that is to produce scientific evidence to make healthcare all these wonderful things that everybody wants: safer, more accessible, more equitable, more affordable. But Ellie, you don't have to close your ears. You need to prioritize AHRQ in this difficult time, because we've been underfunded for so long. And yet with this mission, we've only been able to do the work that we do, which is fantastic work, through partnerships, but our partnerships have been starved because of the lack of funding. We do our work, as many of your partners are non-governmental groups and professional associations. We also work with healthcare systems and the healthcare industry, but we also work with local agencies, federal, state, and tribal and local community agencies. So it's a huge network of partnerships, very much like your alliance. And we hope that your alliance will recognize the importance of AHRQ and its mission. Next slide, please. Well, we at AHRQ have our priorities aligned with the president's and the secretary's mission to transform our healthcare system for the better, but for the better for all, not just some. And so our alignment, particularly going forward, is looking at how we really dismantle the structural racism that exists in our healthcare system and respond to the issues that the COVID pandemic has made so apparent, including the fact that so many people have been infected by COVID and have persistent symptoms and other kinds of issues, neurological issues that persist. And so we're taking the lead on how we actually address long COVID, while NIH tries to figure out what it is from a biomedical perspective. There are still hundreds of millions of people who need care now and into the future. And that's part of what we're trying to do. We're also trying to recognize that we've been in a mental health crisis for far too long, in particular our children, and how we actually integrate behavioral and mental health care into our care system is extremely, extremely important. And finally, we're also looking at the impact of climate change on healthcare. Most people don't even think about it. They think about the medical emergencies that occur because we have tornadoes or floods, but we also have a huge carbon footprint that's being produced that's really a patient safety issue. And that is, we have lines, we have all kinds of medical equipment that are disposable. And so the production of that equipment, the use of that equipment is contributing to this climate problem that we have. And that climate problem fundamentally becomes a patient and health professional safety question, because how we deal with these disposable lines and disposable equipment is fundamentally, if we do away with them, it becomes a patient safety issue. If we replace them with something else, it potentially creates a hazard for our health professionals and for our patients. Next slide, please. So our goal is really to improve the lives of our patients, obviously, by helping them gain better outcomes with the encounters that they have with our health professionals. But more importantly, I've tried to put at the center of what we do also this dyad, the dyad of the patient and the health professional, because what the pandemic has made so clear is that the work experience and the working experience of the health professional affects the overall quality of the interactions between the patient and the health professional. And so we've got to focus on both enhancing the working experience of health professionals so they don't burn out, but also so that their interaction is optimal with their patients. And we do this through our competencies here at AHRQ, through health systems research, through practice improvement, and through our data gathering and analytics, which are used to try to monitor the workings of the healthcare system and to improve decision-making for policymakers. Next slide, please. Well, as I said, we're one of 4 agencies in the department that actually engage in scientific work. NIH, of course, focuses on developing these biomedical cures and understanding the biomedical underpinnings of illness and disease and illness burden. FDA focuses on making sure those discoveries for treatments are safe and effective. And CDC, of course, deals with the large set of social and economic and environmental issues that influence the illness load. So AHRQ is really the only agency with the authorities to look at how we in fact focus on improving care through a science-based dissemination and implementation efforts that have been going on here for quite some time. Next slide, please. Well, this is my kind of simplified version of what the healthcare system looks like. It's really built on 4 pillars. It's built on a set of tools that most of us know, whether it's drugs, whether it's health professionals, how we organize those into healthcare systems, delivery arrangements. It's about consumer behavior and how we prepare consumers to be patients so their patient interaction is optimal. And it's also about understanding the illness burden. And fundamentally, AHRQ is part of this knowledge generation activity that's really science-based, that tries to help health professionals understand what works and also prepares patients to ask the kinds of questions that they need to ask their healthcare providers so that that interaction, that dyad, that exchange of knowledge and experience, in fact, results in effective medical care. Next slide, please. I just want to give you a couple of examples of how AHRQ's work covers the 4 pillars. AHRQ, as I said, really focuses on developing the kinds of tools that makes healthcare safer and transfers knowledge to health professionals about how to use the various tools and how to organize the various tools. It also helps people understand how to develop the kinds of health delivery systems that are most effective based on what we know works. We have a number of programs, Team Steps, our knowledge development and implementation arm. We do a lot of activities taking advantage of the work that our sister agencies develop, the evidence base that SAMHSA provides for specialized mental and behavioral health practice, FDA's knowledge and safety of the new medications. That's all brought together in the work that we do as we transfer that information and knowledge to the health professional and to the patient. Next slide, please. Similarly, we work with our partners at CDC and NIH, where we convert their biomedical knowledge and increased understanding of disease and the development of new cures into real-time therapeutics. And we do that through a number of activities, including AHRQ's evidence-based program, which is now celebrating its 25th anniversary. And our clients are CDC, NIH, HRSA, and a variety of other of the federal agencies, as well as professional societies that develop clinical guidelines. All of that is used to convert these discoveries into real therapeutic practices. Next slide, please. This is a convoluted way of looking at how AHRQ does its work. It's involved both in health practice, that is creating learning health systems around the country, understanding how the data that's collected from different health systems and different sources are brought together so that we can really understand in a systematic way how to provide guidance that supports decision-making at the clinical level as well as at the management level. But fundamentally at the base is the scientific knowledge generation activities that we engage in, the research, the systematic reviews, the guidance that we provide. And it's fundamentally about how we make that interaction between the patient and the health professional the most optimal possible. Next slide, please. Well, the president has put forward a fiscal year 23 budget that is actually, for most of you, we're not talking about millions, billions, which you're used to talking about when you talk about NIH. We're slated for 415 or 16 million in discretionary funds. That's still an increase of 19% above what was enacted for final action for 22, which we're trying to work with right now. We also are slated to have about $111 million from the Bikori Trust Fund to really work on our dissemination and implementation activities. So I think this gives you some sense of sort of where we're going. Next slide, please. This particular budget focuses on those areas that I had mentioned earlier. It's focused on how we actually get a handle on the long COVID care that we're already behind on. It tries to deal with maternal health care initiatives, as we've seen maternal mortality, which has been an unusual issue to arise. Most of the time, at least in my experience, maternal mortality is related to health systems deficiencies. And quite honestly, that's probably where most of our attention needs to be focused. And part of addressing that is really trying to build this all-payer claims database, which allows states to gauge where they are with other states and also provides greater information nationally for the kinds of policy decisions that will need to take place over the course of the next decade or so. Next slide, please. So AHRQ is funded to do scientific research that promises to make healthcare better. And we can't do that without good partners. And you're the partners. The Alliance members are truly our partners as well. And we are trying to address some critical issues that the pandemic has put on our plate, all of us as healthcare professionals and as members of health systems or people trying to run healthcare systems. One of the things that's caught my attention most is the decline that we've seen in patient safety. But it's not only patient safety, but it's also professional safety. The fact that we didn't have PPE or that we've made PPE so difficult for people to use and to get in and out of has created all kinds of other kinds of problems. All the patient safety that we were able to achieve over the previous 5 years before the pandemic has basically been lost or has been made worse in such a way that we have got to address this now. It's become extremely costly and it's extremely deadly. So I look to you for assistance and for support as we move forward to try to keep this promise of a better healthcare system in our sights and to take advantage of this narrow window of opportunity to actually make breakthroughs in improving a complex healthcare system more functional. Thank you, Ellie, for giving me this opportunity to chat with your alliance and to really illustrate sort of where I think we need to go with AHRQ and to move our science forward to make it more practical the way Senator Porter used to say. He used to talk about wanting to see the scientific discoveries really find their way into our everyday practice. And that's really the mission of AHRQ.
This is a really terrific and informative presentation. And I think one of the things that was striking to me is, that you talked about two types of research that AHRQ is responsible for that are both so important. I think about two examples that I'm just familiar with. One where AHRQ funded study compared treatment for preemies, two different approaches, and in that way showed that there was one where life expectancy was significantly higher. So, just as important as a medicine in terms of saving lives. And the other one was, the famous variation in healthcare across the country.
Yes.
And how much good can come from finding out what the best care is out of that variation and then bringing everybody up to that standard. So that health systems focus and then kind of a granular focus on particular modes of treatment, that AHRQ does both. AHRQ research manages both. And
in fact, it's talking about this reminds me of a study that we did looking at really 5 different modalities of dealing with the urinary tract infections. Now, as it turns out, no one therapeutic approach was the magic bullet.
Wow.
But depending on what your environment was like, where you were being treated, what kinds of resources were brought to bear, made the difference in what was more effective than another. And without understanding that, we often are wasting resources, or we don't have the resources that are recommended because there's some sense that one approach fits all. And that's just not the case in the United States. We're a very diverse country. We have very different regional expectations among our populations about what health and healthcare delivers, that we need to understand those and be nimble enough to respond to the differences in resources that are available, but also expectations of our patients and the limitations that, quite honestly, my colleagues in the clinic face. For those of us who come from rural states, my colleagues who practice in rural communities, quite honestly, don't have all the resources that we had, for example, in Albuquerque at the medical center, and trying to figure out how we moved out resources so that they can, in fact, pursue guidelines was part of our job, or part of my job as the Associate Director of Community Health. So understanding these things, understanding from a scientific perspective what makes sense, so that we're not wasting investments is extremely important, particularly in resource-strapped communities.
I love that example because it talk about fiscal impact, a very, very common health problem. And then it's also, that's our day-to-day lives, right? You know, those are things that really make a difference. And one of my wish lists for AHRQ would be a center of research at AHRQ for rural urban disparities and how to address that. And then another one for racial ethnic. And you talked about structural racism. What do you think is the most important next step that AHRQ funded researchers or AHRQ itself could take to kind of concretely move that needle?
Well, the ACA actually has given the AHRQ the authorities to really focus on primary care research. And to rebuild our healthcare system really requires a focus on how we improve primary care across the United States. Fundamentally, it's about how do we do the primary care research that's necessary at two levels. First, to look at those kinds of common illness burden issues that primary care practitioners see and make them better. Provide them with the kinds of knowledge that's necessary so that the interactions they have with their patients lead to better outcomes. And the second is really about how one organizes and delivers primary care. And that's really the systems issue. And
Right.
as you suggested, we try to work on both parts of the equation, but the ACA actually created a Center for Primary Care Research here at AHRQ that I think nobody knows about, or at least it's been discovered by the department as we are trying to address and respond to the COVID pandemic.
Because it can be a locus for all the other goals, right?
Yep.
It can, that's really great. Like, what diagnostics are missing?
The problem is that again, you know, the thinking, we probably have tens of millions of dollars of things that we could implement almost immediately.
Wow.
We have maybe we got $2 million last fiscal year, and we're slated to get another $10 million this year. That's not the scale of the United States.
No.
So I'm trying to figure out how we leverage what we have with our partners, your alliance members, so that we can stretch what resources we do have available to cover the needs across the United States. And part of that is partnerships with the leading healthcare systems that serve hundreds of millions of people in the United States. And so particularly dealing with the patient safety issue, it's really an institutional culture issue that CEOs and boards need to understand affect not only the patient, but affects their workforce. And if we can do that, even with the limited resources we have, then I think we can make some major progress in recovering from this pandemic.
Well, our job as advocates is to make sure you have more resources, and you know, a huge goal for Research America, huge goal. Hey, Anna, why don't you join us? I know there are audience questions, and I said I don't want to dominate. I could ask a million questions. So
yeah, no problem. So yes, as a reminder to folks, please feel free to put your questions in the Q&A box for the chat, and Ellie and I will do our best to ask them. So one question that has come in, Dr. Valdez, you discussed interfacing with other HHS divisions, but could you speak a bit more about AHRQ in relation to other research partners like PCORI and also academic researchers?
Sure. PCORI is a central partner of ours. We're funded under the trust fund to take the findings of PCORI researchers and implement them, or see that they're implemented in the practice setting. And so we have an effort that's underway now. We have a framework that we've put forward as a strategic plan for moving that forward under the current administration.
Great.
We're still open for comments and suggestions, so I will make sure that you have the link to share with you.
That'd be great. So this is dissemination, Dr. Valdez?
It's both about disseminating the findings of PCORI work, but more importantly, how you move to the next stage of implementing, that is adoption of these findings into clinical practice. And so that's part of what I mentioned. We are slated in the fiscal year 23 to get about $111 million to support that work.
Wonderful.
But as you know, as we're talking about the nation, that's a pretty slim amount.
Right.
But that's got to be done with our partners, and we do that on an ongoing basis. We have our evidence practice center has contracts with many of your alliance members who serve as practice center contracts that we do task orders for, and that often produce evidence-based recommendations for our other partners, whether it's a health system, private health systems that we've been working with, or academic medical centers that are health systems that need to understand the findings that are available and different ways of organizing and delivering care. We've also worked with professional societies as they work to develop professional guidelines for whatever their subspecialty happens to be. So those are also our partners beyond the federal agencies of CDC, HRSA, SAMHSA, and NIH, of course. With NIH, we help them develop their research agendas, identifying fundamental gaps in our understanding that then lead back into that effort of biomedical research.
Oh, that's terrific.
That is, absolutely. So another question, Dr. Valdez, this person is actually asking, according to a survey recently commissioned by Research America, COVID-19 and the cost of healthcare are the two most important health issues to most Americans. And you spoke, of course, about COVID-19. Can you talk a bit more about how AHRQ is handling or approaching the cost aspect or the cost issue?
Yeah, we're actually one of the only agencies left that has an economic analysis unit. And so we've been working with ASPE, the Assistant Secretary for Planning and Evaluation, to look at and understand the cost of COVID, both the system's cost, but also potential costs for interventions that need to be taken. We run several different data sources that are used by decision makers, both in the private sector as well as in public sector, both at the state and at the federal level, to understand the operation of the healthcare system, the cost of the healthcare system, both at the hospital level, but more importantly, broadly, looking at nursing home, hospital, and all the different settings in which care is delivered. The all-payer database that I described is a new initiative that we're trying to put on the scene that would support a national look at how our costs and our expenses for medical care are distributed across the country. We have about 20 or so states that have adopted their own all-payer systems, but that leaves the other half of the country without an all-payer system to consider how their expenditures are going, where they're going, where are their opportunities for savings. And so this is our effort to try to both provide states with benchmarking, very similar to what we did with HCUP and hospital costs, that allow them to plan ahead and to set targets for their expenditures at the state level. Because quite honestly, healthcare is still local, and the states have a big role to play in this area. And so part of our role as the federal government is to work with our partners in the states to understand how to control to plan for cost savings and cost increases and all the other kinds of craziness that goes on around how we actually deliver healthcare in the United States.
You know, this is Dr. Valdez. It's really a priority for Research America because, as AHRQ research demonstrates, we're in a system, and so if you treat one piece of the system as if it's in a vacuum, what are the interactions, right? So if you just go after drug pricing, what happens with hospitalizations? And what happens with primary care, utilization? And so if there were a way to get more at the interactions between different parts of this system, we think that there would be a greater focus on medical progress. That's our bias, and public health progress and the importance of innovation. But right now, the ability to look at the system as a whole and see how the parts all fit together and what levers,
Well, that's part of what our data and analytics group is trying to get a handle on.
That's awesome.
We have multiple different data systems, and one that has been sorely underinvested in is the HCUP program, which we're also trying to put information about climate change and climate change effects so that we can better understand the resilience of our healthcare system and our healthcare delivery in different parts of the country.
That's great. Forward thinking.
Absolutely. So another question that's come in, Dr. Valdez, this person is saying, physician scientists play a unique role in the healthcare system, bringing discoveries made at the bench to the bedside. And could you speak about your thoughts on increasing the number of physician scientists in the US?
Yeah, in fact, this is part of the second half of the PCORI Trust Fund dollars that I didn't get a chance to speak about yet. And that is, while we're focused on dissemination and implementation, we're also funded through PCORI to train new researchers in P4 type research. And part of what I'm trying to do is also to recognize that our PCOR research methodologies have kind of become stale given the new sources of data, the new opportunities for doing different kinds of analytic work. So not only are we looking at training new clinician researchers, but we're also looking at new PCOR methodologies that are necessary because while there's a religion around randomized clinical trials, randomized clinical trials is really only one source of knowledge. And we need to do a better job of developing the other methodologies that are available to us today. The deficiencies in randomized clinical trials have long been recognized. They've often been ignored, but it's not something that AHRQ can afford to do in our evidence-based work because we need to also understand the external validity of those findings, which are usually found in very self-contained trials. You can't just take a randomized controlled trial finding and translate it into or push it into a clinic.
Research in the wild.
So,
yeah.
So it's that's the part of the work that we need to do, and we also need clinical researchers who can help us do that kind of work.
That's terrific, and I mean, it's so important to patients, right? That research results recognize the variation in real life, and that's where the patient voice is so important.
Absolutely.
And I know AHRQ and PCORI both really value and incorporate patient engage,
and that's why I'm really trying to help people recognize we want to be patient-centered, but we also want the dyad, that interaction of patient and health professional, to be the core of how we look at a medical visit, a healthcare visit, whether it's medical or behavioral health or whatever it happens to be. It's going to be the patient, and the patient not being an individual, but being the patient's constellation, their team, their caregivers, particularly as we move and recognize that we have an aging society many of our patients are increasingly going to not be there on their own. They're going to be relying on other caregivers,
Right.
their kids, their neighbors, whoever it happens to be. It's that care team on the patient side as well as the care team on the professional side.
Right.
And that's how our patient-centeredness concept needs to evolve to recognize these dynamics in our society.
It's a wheel with spokes, right? Makes a lot of sense. Anna, do you have other
Absolutely.
questions?
Yes. Another question, Dr. Valdez. This person's asking, has AHRQ ever developed a needs list of critical healthcare interventions that are needed going forward?
Yes, in fact, we have. And if you come to our website, you can actually find a list of areas that we've identified as major gaps in our understanding and knowledge, other areas and that we're hoping we can figure out how to get funded so that we can provide that knowledge. We also have a site for individuals to nominate areas that need to be investigated or examined. So we very much want our stakeholders to help us know what they consider to be priorities so that can also be in the mix. Certainly we don't expect to be the ones to say and know everything that's missing. We can only identify that through our interactions with stakeholders, with our partners who help identify what the priorities ought to be.
Very cool, as Ellie said. Another question, Dr. Valdez. What do you think are the most important lessons COVID-19 taught us when it comes to healthcare? And what did COVID-19 reveal about gaps in health services research, or did it mostly produce new research needs?
Well, I can only tell you what COVID-19 taught me on a personal basis. And I think we all have personal stories. COVID-19 illustrated for me how our system is so terribly fragmented, and that when patients seek care in one setting and then they get moved on to another setting, they get lost. They get lost to the primary care physician who may have sent them to a hospital and the person was then later being taken care of by a hospitalist, or they showed up with COVID and went through the emergency room and ended up in intensive care, but their primary care physicians or others who had been taking care of them were unaware that they in fact had been in the intensive care ward or that they were dying. It's illustrated for me the fact that we have a fragmentation that not only affects the transition of care, but it also affects how we actually deal with a whole variety of just communications issues among team members. And so part of what AHRQ has done over the years is illustrated the importance of team and team communication. And part of that showed the pandemic illustrated how fragile those successes that we've had have failed during the pandemic. Part of the reason we saw the patient safety issues rear its ugly head is that those team efforts, because of the stress and strains that our health professionals have gone through, because of the strains that our health systems have gone through, routine patient safety procedures and activities dropped off or dropped away to be secondary to deal with the crisis issues that we had. We've got to be a system that operates through a crisis, not just responding to a crisis. And we can only do that if we rebuild our system so that it recognizes that it will face crises off and on, and this is not the first and it won't be the last. And that we need to be able to continue to do the kinds of routine procedures and reporting that's necessary to maintain patient safety, to do good transitions from one setting to another, and quite honestly, to communicate better. Both communicate better within the professional community that's caring for a single patient or a patient's family so that they know what's going on, but also communicate more effectively with our patients about what's happening, what can be done, and where they can seek the kind of care they need.
Absolutely.
Very, very true. Another question that has come in, Dr. Valdez, we have heard that many people forewent screenings, as you just said, during the pandemic, particularly the early days of the pandemic. What do you see for the role of the U.S. Preventive Services Task Force to help with new recommendations and the backlog of screenings?
Oh, I don't know if it's the task force that needs to address that. I think we have another set of activities here at AHRQ that's trying to recognize and move forward the issue that the task force has a lot of recommendations that are already in place, that that the vast majority of Americans haven't had their service providers, whether it's a physician, a nurse practitioner, a clinic, or a health system, create a systematic approach to make sure that all of the recommendations, for example, adult vaccinations, something quite simple intervention, take place for their patients. I recently moved here to Washington, D.C., and so I've had to move from the University of New Mexico health delivery system, which is where I was receiving my care, to a new system here in the D.C. area. Thankfully, the healthcare system I've joined has a very organized system that immediately registered me, sent me a whole lot of information saying, you're an adult of this age, you should have this, this, and this. Our records indicate that you don't have any of those things. And of course they do, because my health system in New Mexico, I've got to take responsibility to have those records transferred over, and that could be months before my new healthcare delivery system knows that, oh, he's actually on track with all his immunizations, or he's missing this immunization because he was on Medicare and he has to pay for this medication or this vaccine, even though it can be injected, covered by Medicare, but he's got to be the one that buys the vaccine itself. It's a weird system we have on the financing side, but it's part of that issue that the task force has done its job, it's recognized, it's made recommendations. Question is, how do we then move those recommendations so that they actually get implemented and fulfilled for those things that we know work and that we know are relatively easy to implement?
Thank you for that. I think we're coming right up to time, but maybe we have time for just one more question. So Dr. Valdez, this person's asking, how can AHRQ prioritize the mental health of healthcare professionals to not only improve their lives, but improve overall patient outcomes as well?
Well, as I said, since coming on board, I've made the well-being of health professionals central to this notion of patient-centeredness. And certainly the mental health issue is one that I've dealt with personally at the University of New Mexico. Many of my colleagues in family medicine, during the height of one of the waves of COVID, were asked to return to the hospital and to provide hospital care. Some of them hadn't been in the hospital since their training days, 30 years before. So returning to the hospital setting to become hospitals was not something they ever expected to do. And so that caused a lot of stress, a lot of strain, anxiety, and in some cases depression. And so I've seen it up close and personal with my colleagues. The stress and strain I felt because when they went off to do clinical activity in the hospital, I was backfilling on their teaching side. So I took up more of the teaching of the first year and second year medical students, for example. And that pushed a lot of stress and strain onto me, not to mention anxiety. I hadn't done that for a long time either, because I had spent a lot of my time over the last decade and a half being an administrator. So now I completely understand the question. How we actually accomplish it is something that I've now pushed our staff here at AHRQ to help us try to understand better how best to do it. And so hopefully if you ask me this question in a month or two, will have a better set of answers than a personal story about how I try to deal with my own personal stress and strains.
No, it's an answer I think we can all absolutely relate. And I know we are bumping up against time, Dr. Valdez. There were a couple other questions. There was one about, I actually remember this very well, when AHRQ was at risk because of a decision that raised a lot of political kind of a backlash, and a question about how AHRQ are there new walls or safeguards that protect AHRQ from political interference and that kind of thing. It's a very tough question, I think, for every federal agency to answer. But if there are a couple more questions we weren't able to get to, maybe we can get to you individually so we can get back to these folks.
Sure, absolutely. If you send those questions on, we'll make sure that people get answered.
Okay, that's terrific. And Anna, I don't know that there's any real housekeeping today other than to thank you, Dr. Valdez, for this wonderful presentation and for joining us. It's a pleasure to partner with you and your wonderful staff, and to advocate for what you're doing. And
well, thank you. I don't know if you know, but I've been a Research America supporter for most of my career, since the beginning of Research America's existence.
Oh, wow.
I had the good fortune of being in the DC area when you guys were formed, and going to many of your honor dinners, and
nice.
It's just been wonderful to be able to participate again this year, as we had that live honor ceremony at the National Academy of Medicine this year. So I want to thank you all for your work, because without you, our agencies and our science would be far behind.
Well, thank you. And you know, we're going to attack you again this year for other events. So be forewarned. And thanks to everybody for joining us today. Absolutely shoot me an email, shoot Anna an email with any questions. And we will follow up on the questions we didn't get to today. So thank you, Dr. Valdez, and thank you, everyone.
Thank you very much.
Bye now.